that you have a quiz. But you have a quiz this Friday, which is a post-quiz, okay? So we'll probably do another announcement for Friday, just to give you a full week of reminders. Make sense? So you should be queued up and ready for cell injury and death. And I had a couple questions like, okay, well I saw the cell injury and death presentation was in last week's folder, it's also in this week's folder, why? Well, sometimes we have a little bit more time the first lecture, and so I'll start this lecture. We didn't, so it was just in there to get you ready. They're the same presentation. There's nothing different about it. Okay, so we're on schedule, but it's not ahead of schedule. So that cell injury and death that's in this week's folder, if you look back to last week, it's also in there as well. Okay, so that's the reason for that. From this point forward, there will only usually be one PowerPoint in that file for the week. All right, first up. Why did the dog cross the road twice? Why did the dog cross the road twice? He was trying to fetch a boomerang. That was my 9-year-old, I'm pretty sure that wrote that one. Okay, what does a peanut say when it sneezes? What does a peanut say when it sneezes? Cashew! Right? Okay. All right, we ready? So, pathology. Last week, we talked about pathology being the study of suffering. Right? Study of suffering. It does a number of the following, right? It helps to bridge clinical practice and basic science. It is that translational piece, kind of like this technology transfer idea that I was telling you about, which is that lecture for the Center for Bioengineering a week from this Friday. Pathology focuses on the investigation of the causes of disease and the underlying mechanisms. Right? The underlying mechanisms is called the pathogenesis, and the causes are the etiologies. This is a little bit of a review of what we talked about last week. Now, if we look at cellular adaptations that take place when we have damage in tissues, we can see that the cell starts out as a normal cell at the top of the slide. And it's very typical. It's not unusual that our cells experience damage throughout the day. They become stressed. They become fatigued. They actually become traumatized. Okay? At the end of a long day, how do you feel? Tired, fatigued, traumatized, stressed. Okay? Very good. I said, okay? And so over a night period of time, your body has the opportunity to heal and rejuvenate itself. And that's why rest is so critically important. And there's been lots of research on what happens if you don't sleep, right? And they've done this in a lot of military applications, a lot of military-funded research trying to figure out if they could squeeze more out of their soldiers and what are the negative implications of doing that. So we have a large body of data now that proves that sleep is absolutely critical. Okay? In fact, there was a study that I just saw that was recently published in the last couple of weeks. And this was a study where they were looking at sleep behaviors in patients. And they recruited patients, kind of not too dissimilar to this research opportunity that's being talked about before class, that little announcement. But this one was different. They wanted to study you in a sleep lab so that you fall asleep and they videotape you while you slept. Okay, it was kind of creepy, but you know, it's all for the sake of science. And they were looking at sleep behaviors and patterns, but you were sleeping in your own room. So they came in with, put cameras on the wall and stuff like that, monitored how much time you slept. And then after that period of time, they did it for like 3 or 4 days, and then they administered the cold virus in a nasal spray, okay? And everybody got it, and there were a couple people that had placebo, but patients received the cold virus as a nasal inhalation, and there was a cliff. Those that had less than 6 hours of sleep were 75% more likely to get sick. everybody was dosed, essentially everybody was dosed with the cold virus. But if you had less than 6 hours of sleep, you were 75% more likely to actually catch the cold after a direct inhalation. Okay? So what happens is we have stress, we have demand that's placed on cells, and there is some adaptation that can take place. Here's one. Our skin cells are stressed every time we go out in the sun. If you stay out in the sun for a longer period of time, there is an adaptation that takes place. And what is that called? It's like you gorgeously tan, right? Some of you, it's burnt red. Okay, I get it. But that's still an adaptation. So the adaptation to the stress, which is UV light, causes the melanocytes to produce more melanin, and that's your natural UV blocker. Okay? And if you have the inability to adapt, like in the case of a sunburn, then you'll have cell injury. Now, if you have cell injury, you're going to see some subcellular changes that take place. Some of them might be reversible, but at some point you may get to a point of irreversibility, meaning you're past the point of return. And now that cell is no longer salvageable. And it leads to necrosis. Okay, and that's one of the topics we're going to talk about today, is necrosis. Well, in addition to that, you may have cell injury, and this may actually stimulate the cell to do something in a more protective, mechanistic way, which is say, all right, well, this cell is no longer useful to me. It's been compromised. I'm going to actually trigger it to die in a programmed way. And so this programmed cell death is known as apoptosis. It's a much more organized process. The cell triggers itself. It's almost like cellular suicide. But it's done in a way where all the business is in order, everything's packed up nicely inside the cell, and it actually sends it out of the cell in order to be utilized by neighboring tissue. And we'll talk about the difference between necrosis and apoptosis, but that is a big theme for today's lecture. Expect to see it on the exam. Okay? So if we look at cellular adaptations, we can categorize them in different ways. We have physiologic versus pathogenic. If an adaptation is physiologic, it's a result of a normal process. For example, like embryonic development would be a physiologic adaptation. We have 4 tadpoles in our house right now. Not like in an aquarium in the house. Okay? Pretty soon I'm going to have to put a lid on top of that aquarium, because what's going to happen? They're going to change, right? They're going to adapt. They're going to go through a hormonal change. They're going to start losing their gills and growing lungs. Their tail's going to shrink, right? Their legs are going to show up. Appendages are going to show up. Their buoyancy completely changes. You can kind of tell when they start becoming, you know, more frog-like. They don't float quite as well. They sort of sink. Okay? These are physiologic adaptations that happen in lots of different organisms. In us, embryonic development is an example of a physiologic adaptation that takes place. Here's another one, adolescence. Okay? Puberty. Hormonal changes take place and the organism adapts to those signals. Now, pathogenic, this results from a disease state or something that's perturbing the system. It's not a physiologic or a quote-unquote normal process. Atrophy. Atrophy is what? What's the definition of atrophy? Shrinking of cells. Okay, atrophy, cell shrinkage. Hypertrophy, what's that? Cell enlargement or cell size increases. Hyperplasia, an increase in cell number. Metaplasia, we gave an example last week of metaplasia. What was that example? Barrett esophagus, right? Where we've got this epithelium that lines the esophageal lining, and it's changing, it's adapting, it's going through a cellular adaptation as a result of the hydrochloric acid environment from the stomach gastric juices. And typically, metaplasia is reversible. You remove the HCl insult, and the epithelium will go back to stratified squamous. So a metaplastic change doesn't always mean it's cancer. It means that something abnormal is happening. It's probably a pathologic condition. But if you took away the injury, you would actually revert back to the normal tissue type. So let's look at a cellular adaptation. And the example that I'm going to showcase here is cardiovascular. Okay, so this is in 202, Bio 202. This is second semester anatomy and physiology, where you're looking at adaptations to blood flow as it perfuses cardiac tissue. So in the middle of the slide, we actually have a cross section, right, a transverse section coming through the heart. It's about midway down of the heart, and this side right here on the right is actually the left ventricle, right? It's the patient's left. And the side over here on your left is the patient's right ventricle, and in between them is what? Structure. What is it? The what? Never mind. Okay. Any other guesses? The tissue between the two ventricles. The septum. Thank you. Okay. So this is the interventricular septum. Right. This is the lateral free wall of the left ventricle. Do you guys remember all this? Vaguely, it's coming back. This is the working side of the heart. Right. This is the side that receives the blood flow from the body, from the superior vena cava and the inferior vena cava. Do you remember all this? Okay. So if we have a normal myocyte, so this is a picture, a cartoon drawing of a myocyte. Remember, they're multi-branched. Okay, they're striated. This is back to 201. And that's the tissue that's inside of the working part of the heart, or the muscle known as cardiac myocardium. Well, if we actually increase the load on the heart, and we'll talk about that at the end of the semester, but if you increase the load on the heart, how would you do that? Exercise could do it, okay. What else? How about in a non-healthy state? High blood pressure. So clogged arteries, atherosclerosis, mean arterial pressure goes up. Okay? So that increases the pressure head that the heart has to work against to eject blood out. So now it's like it's lifting weights. Well, cardiac myocardium is very similar to skeletal myocardium. You remember that from 201 from our tissue comparisons. And so if you load skeletal muscle, right, and you lift weights with skeletal muscle, what happens? Use a fancy word that we just talked about. Hypertrophy. Okay? If you load cardiac myocardium, hypertrophy also happens. The myocytes enlarge. So look at what happens here. You increase the load, the cell itself adapts, says, okay, I'm going to be working harder, so I'm going to increase in size, hypertrophy. And you can see the result grossly. The septal wall gets thicker, the thickness of the myocardium is greater. And this is cardiac enlargement of the heart due to high blood pressure. If you remove or lower blood pressure, you can get back to this state at some level. Now, here's a different pathway. This is cell injury. Here, this would be an example of something if you cut off blood flow to the heart. You cut off blood flow to the heart, now the heart itself isn't going to have enough oxygenation in order to support the tissue. And so you're going to get cellular death. Right? You're going to get a myocyte that is injured, and it could be in a case of reversible injury if it's within essentially like the first few hours of loss of blood flow. And that's why with an acute infarct of the heart, response time is so critically important. Have you seen these new commercials now? There's this commercial for some hospital network in the valley, and it's just people that, old people, but they look good, okay? And they're holding up these placards, right? It's like response time to when they have their cardiac stent placed. Have you seen this commercial? And they hold it up, and it's like 45 minutes, 20 minutes, right? It gets progressively, lower. And they're bragging about how quickly they're able to put in a stent to open up the blood vessel that was clogged of the patient's heart to reestablish blood flow. Because the whole point of that marketing campaign is there is a critical phase where you are still reversible as long as you reperfuse the heart with blood flow. But if you don't do anything, you're going to lose that tissue, and that's what's shown over here. This is actually a cardiac infarct. This yellowish and then a little bit of black over here, this is what it should look like. This is a wedge. Looks kind of like a pie wedge here. And this is a cardiac infarct, also known as coagulant necrosis. We'll talk about that here a little bit later. Okay? So there's a point of no return where you can't reverse the cellular injury. All right, let's talk about atrophy, loss of size. That was hypertrophy, that was cellular death. Now let's talk about atrophy. So here are two different brains. And you've got a younger 20-year-old brain on the left. Okay, that's what your brain looks like. And you can see on the patient's left hemisphere, the meninges have been stripped off. And this is an older patient in their 80s. Again, this is post-mortem, of course. And the same thing has been done here, as this meningeal tissue has been stripped off. And the whole point is, these patients were about the same size, relatively speaking. Weight, body size. But you can see that, and the brains are about the same shape. But do you see the big gaps of the imaginations of the gyri? Can you see the difference between how much tissue loss here versus a young, healthy brain where it's much more sort of plump, if you will? Okay. So over time, in an older patient, you get a restriction of blood flow to the brain because you get vascular disease that happens all over the body. And it may not cut off completely the carotid vessels that perfuse the brain, but if it narrows them, say they have a 20% narrowing, not going to kill you, but the brain itself is getting only 80% of the blood flow that a 20-year-old would get. Or let's say it was 40% narrowing. You really don't treat carotid vessels unless you're like 75% narrowed. So 40% narrowing, 50% narrowing, and if the patient's 75 years old, it's not worth treating. That sounds terrible, but the risk of treating is far worse than the possibility of not treating, right? If they have a 45% lesion of occlusion and they're 75 years old, the doctor's probably saying, I'm going to put you on some medication and just enjoy life. We're not going to go in because if I go in, now here's all the risk factors of just doing the procedure. And one of those risk factors of 75-year-old is going to be death. Okay? So slowly decreasing blood flow, you shrink the neural tissue over time. Atrophy. Okay? This is not a stroke. Some students think we're talking about stroke. This is not a stroke. This is just slow narrowing of the vasculature over time. If you eat McDonald's for 75 years, slowly over time your vessels close up. Okay? Hypertrophy, an increase in cell size. Now, in this picture, we've got histology on the right. Bless you. And we have the gross image on the left. This is actually physiologic hypertrophy as a result of pregnancy. So that is a uterus on the left. Okay, it's called a gravid uterus when it's enlarged like this. And this is a normal-sized uterus right next to it. So that's what it looks like under normal conditions and grossly, and how much enlarged it can become. Now, if we look histologically, this is a normal uterus right in the middle. This is a histological section of hematoxylin and eosin. The reason you know that is it's pink and purple. And the pink is staining extracellular tissue. and the purple identifies the cellular nuclei. Okay? And this is uterine tissue, so these are spindle-like, narrow-looking smooth muscle cells. And the way that you would see that is if you focus like right here, do you see how this nuclei is kind of elongated? It's elongated because that cell is elongated sort of in a spindle-like fashion. It's kind of fat in the middle and thins out on the edges. If you contrast that with physiologic hypertrophy, do you see this one right here and this one right here? Here's a dot with the cell around it. A dot with the cell around it. A dot with the cell around it. So the nuclei are not elongated. So these cells are all swollen and big and plump. And that's the hypertrophy that you see in a gravid uterus right here. An increase in the cellular size. Well, you're also going to see in pregnancy, physiologically, you're going to see hyperplasia. So you do see both. Because not only are you increasing the cellular size, you're also increasing the number of cells as you prepare the endometrial lining for implantation. Okay? So, and then lastly, if we look at metaplasia, which is what we talked about last week, at the end of last week, we see metaplasia is a reversible cellular replacement. So in this particular example, we're looking at the basement membrane on the left. And we're in the epithelium of the lung. This is a second example of cellular metaplasia. Last week we were in the esophagus, now we're in the epithelium of the lung. And we have ciliated columnar epithelium normally that takes place. And you can see that there's this transition zone where you're going to get squamous metaplasia. This squamous tissue is not supposed to be there. This is the corresponding histological section. Again, a hematoxylin and eosin stain section. You can see there's far more nuclei because there's more purple dots. And so lung tissue is more nucleated than smooth muscle tissue. And you can kind of appreciate the cilia at the surface. Here's this transition zone with this slope, which is right here where this artist kind of drew that. And this is stratified squamous epithelium now. Now, what do you think would cause the lung epithelium to move from a ciliated columnar epithelium, right? And that's good for what? What is that good for? What's that? Bringing stuff out, right? Everybody do this. Come on, let's go. Nice. What did you do with it that came up? Oh, you swallowed it, right? It's socially acceptable, we just never point it out. Okay? But every time you cough, you're bringing up with this respiratory escalator, as we called it, 202, you're bringing up this mucus layer that's full of debris. What do you think would cause, in the lungs, this to change to a squamous metaplastic situation? What's that? Smoking. Okay? Why? Why does that make sense to you? Because it's an irritant, it's abrasive, right? It's causing injury to the epithelial lining. So the body is going to respond very much like what we saw last week with Barrett esophagus. Just a different stimulus. So now you have two classic examples, one in the respiratory tract and one in the gut, GI tract, and the esophagus, of how an injury will cause a change at the level of the cell. Make sense? So if we follow this out, and we look at a smoker's lung, this is histology that comes from the University of Iowa, and we're going to zoom in here a little bit at 40x. Now we're focused in on this particular section of human lung, and we're at the level of the primary bronchi. And at this level, you can appreciate on this side, you can kind of make out these are columnar epithelium that you would expect to see in normal lung tissue. And as you move to the right side of the slide, now you're starting to see, here look at this cell, how it looks sideways, right? Flat. You're getting squamous metaplastic epithelium in this smoker's lung. Okay? So these were some of the things that we would look at if we said, okay, we see a lesion in this patient, we're going to take a lung biopsy, we're going to look at the tissue, and you might say, okay, I see a lesion, but here's the good news. You don't have cancer yet. Okay? Here's the bad news. If you keep smoking, this will likely turn into a cancerous mass. And I would say that this is a stage of precancer. And then doctors like to say that because then it motivates the patient. So I don't have cancer, but I have precancer. Okay, so I better stop smoking. Okay? So that's how that would play out in that particular scenario. Questions so far? Mostly over Barrett esophagus or smoker's lung tissue and the metaplastic change that take place there. Okay. As we move on, we've looked at hydrochloric acid and we've looked at pollutants that can cause cellular injury. We've also talked a little bit about UV light. So this semester we're going to see lots of different examples of agents that cause injury to biologic tissue. This is by no means an exhaustive list, but it's definitely a list that covers pretty comprehensively what we're going to talk about. So, hypoxia at the top of the list. Hypoxia is what? Low oxygen. Okay? Low oxygen. Now, low oxygen can happen in our cardiovascular example with the heart. How do you get low oxygenation of the heart? Ischemia, how does that happen? It's a blood flow issue, right? The heart's either not pumping or there's a blockage of getting the blood from where the heart ejects it to the tissue of the heart itself. Okay? Reactive oxygen species. This would be the opposite. This would be hyperoxia. Too much oxygenation. If you have too much oxygenation in tissues, you can get what we call free radical formation. And these free radicals are what we call ROSs, reactive oxygen species. And those reactive oxygen species, what they like to do is they like to go bind to different compounds and cause trauma to the tissue. Now, sometimes that can be used as a positive thing when we're talking about inflammation, and I'll explain a little bit later. Okay? But reactive oxygen species is a technique that a macrophage uses in order to kill bacteria, but it contains it within the macrophage. Okay? And reactive oxygen species just floating about in the tissue, being able to react to lots of different things is not a good thing. It will cause harm. Chemicals like hydrochloric acid. Infectious agents like bacteria or viruses. Various immunological reactions like hypersensitivities. How many of you have an allergy to anything? Right? Like this class maybe. How many of you some of you are allergic to pathology. You think so, right? It gives you a headache, right? Keeps you up at night. Loss of appetite. Okay? Excessive drinking. These are all signs of diseases, okay? So maybe you are allergic to pathology, but how many of you actually have a real allergy, like a food allergy, an allergy to a drug, okay, pollen? So that actually can cause a pathological response. So let's take an example. How many of you are allergic to like pet dander or like certain pollens? And in certain part, you can go into somebody's house, you're deathly allergic to cats. What happens to you? Lots of mucus, lots of sneezing, lots of redness of the eyes, the nose, right? Hard to breathe, maybe. The tissue is responding. So that's a pathological response to hypersensitivity to an antigen. So we're going to talk about that this semester. Genetic defects, nutritional imbalances, physical agents like trauma. Okay? Aging. The aging process itself causes injury to tissues. And we know that. We can see that happen in patients where you look at an injury of a young patient in their 20s, and that same wound in a patient in their 70s is going to take twice as long to heal. Inevitably. What's that? Well, so we call it pathological because we still don't have a good understanding of why we age. Right? So we know the body can...
Kind of a normal
Yeah,
process.
it's sort of a normal process, but if you think about biology the way it really works, it really shouldn't stop working. There's no real good explanation as to why it wears out. Does that make sense?
Yeah.
So it's kind of an interesting concept. We'll talk a little bit more about it, but our body does a really remarkable job of regenerating itself and healing itself. So why does that stop happening? There's lots of great theories, but nobody has a great answer. Okay, so the aging process is still in this category of a pathology. Okay, and if you talk to physicians, they'll tell you that too, especially surgeons. They'll say, you know what are the pre-existing conditions of this particular patient before I go in and do open heart surgery? Age is definitely one of the factors. Okay, do they have a kidney transplant? Are they diabetic? Are they overweight? How old are they? Is always on the list. Okay, so good question though. I mean, it's a little philosophical, right?
I wasn't sure.
Yeah, no, it's a reasonable question. It's a little philosophical, but you know, these are some of those things that make you go, why is it that we age? It doesn't really make a lot of sense. Now we have reversible and we have irreversible injury. On the reversible side, when we have injury to a cell, we're going to see the cell swell. So take a sunburn, for example. Back to our sunburn example. When the tissue becomes damaged, right, you get definitely swelling that takes place. And the swelling that takes place is because you increase the blood flow to the region. That's another reason that it gets red. That's another reason that it's hot to touch. Okay, if you've had a sunburn, then when you touch that sunburn, I mean, you can feel heat radiating from the sunburn. Okay, because you've increased the perfusion of blood to that particular tissue. So you're going to get swelling. You also get what's called a change in, or fatty change, a change in the fatty content. The inside of the cell is starting to alter and trying to make a decision, am I going to die or is this injury not going to be life-threatening to the cell? And are you going to survive it? So the fatty change is the cell itself starts taking more of a vacuole-like appearance as it starts deciding if it's going to hollow itself out. Now, irreversible is cell death, and there's two main processes of cellular death. One known as necrosis that we alluded to, and one called apoptosis, which is a lot more programmatic. It's more organized, right? It's more intentional, and the whole point of apoptosis is to try to package the inside components, like the cellular organelles, into usable material that the neighboring cells and the neighboring tissue could actually take advantage of. So if you look at some of these pictures, you can see this normal cell right here. You go into this zone here of reversible cellular injury. You get some swelling that takes place, okay? And if the injury goes away and the cell is able to recover, it can come right back into its normal phenotype. But if it passes sort of this point of irreversibility, you get the cell moving into a necrotic phase. And in the necrotic phase, you actually start losing the integrity of the membrane, and it has holes that are put into it. In fact, in a necrotic format, the cell takes on this moth-eaten appearance. Okay, have you ever seen a piece of clothing that's been eaten by moths? Right? It's got all these holes in it. So this moth-eaten appearance is the cell membrane itself becoming compromised, and now you lose all sorts of ionic gradients that you've spent a lot of energy creating. Okay? And if you don't have those ionic gradients, how can you make ATP? How well can you make ATP? Not well at all. And if you can't make ATP as a cell, how long will you survive? Not very long. Okay? All right, so this is kind of the overview of reversible versus non-reversible or irreversible. So when we have cellular swelling, what's taking place? And what are some examples? Let's talk about that. Well, we get this hydroptic change. We get a change in the organization of water within the cell. A lot of times you get cellular swelling, so you're going to get more water within the cell itself. So the volume of fluid inside the cell goes up. You get a vacuolar-like appearance. It is reversible to a point, and we'll show this, we'll talk about this. At the level of the organ, it will cause an increase in the weight of the organ because of the amount of fluid that goes in. Right? So organ weight will go up because it's retaining water, because of that hydropic change. You'll have an increase in the pressure, or the Turgor pressure. Right? Someone was talking about 182 in plants, right? So this is actually somewhat relevant. Right? The Turgor pressure in plants, why is it important? You guys remember? What is Turgor pressure good for? Right? Turgor, what's that?
Keeping the plant standing?
It keeps the plant standing straight up. That's the Turgor pressure. So if you don't water your plant for a week or two, what happens? Turgor pressure goes away and it wilts. As soon as you give it some water, right, you can kind of reverse that and it stands back up. So if you increase the Turgor pressure inside of a mammalian cell, not a plant cell, you're actually smashing all of the organelles up against the wall of the cell because it's not designed to handle it like a plant. Okay, there are some big differences between plant cells and mammalian cells. But the Turgor pressure is still the same concept. So that increase in pressure inside the cell, doesn't make us stand up straight. Okay? It actually causes damage because the cell contents get smashed up against the membrane. The color of the tissue will become more pale because now you're actually diluting it out. You're putting more water in there, so you get more of a palish-like color. At the level of the cells, you get these vacuoles, these giant empty spaces that form. So let's look at some of the histology. Do you guys have any guesses as to what this is on the left? Kidney tubules. Very good. Okay? Either you read the chapter, or you remember this very well, or you've already looked at the slides, which is exactly what I want. These are normal on the far left. You could write, if you're printing out slides, normal. Right? Kidney tubules. Is that important to know for the exam? I would say yes. Okay? These are simple cuboidal epithelium. You remember that? So they allow for a lot of filtration and secretion. Well, the kidney itself receives about 34% of the blood flow straight off the aorta. You guys remember that? Right? Because the renal arteries come right off the descending aorta and go straight to the kidneys. Because it filters the blood pretty quickly. Well, the kidney itself actually receives perfusion to keep the tissue alive, which is independent of the renal arteries. But if you have an infarct in the kidney, or you have disease of the vasculature, and the kidney doesn't get blood flow, it becomes hypoxic, right? And then let's see what starts changing. Do you see this picture right here? You can still make out, here's a kidney tubule right here, here's one right here. What do you notice about this cell versus like this cell right here? Or this cell versus this cell right here? Or what's that? So they're starting to swell, like the nuclei look wonky, right? You can already see that there's loss of integrity here at some level. And this is still, some of this would be reversible, some of this would be reversible, this would be reversible, this would be non-reversible right here. This is non-reversible all the way through. This is remnants of necrotic kidney tissue on the far right. Okay, so that's a necrosis process that's taking place slowly as you progress over time. Yes?
So, nuclei.
Yeah, so these guys over here, the nuclei themselves are starting to diminish in size and content. They're basically just dissolving away. Here they're still maintained, and that's why if you have a normal appearing nuclei, like these right here, that look like this. Here's some wonky ones up here that won't be able to remanufacture the contents of the cell. But if you have an intact cell membrane and you have an intact cell nuclei, you can still regenerate everything that cell needs to survive. Does that make sense? That's why it's still reversible. But over here you can see that these nuclei no longer look normal, which is a really good observation. So now, these are anuclear. There's not even any nuclei in this one. So this one is completely gone. There's no way it can regenerate anything because there's no nuclei to transcribe and then translate any of the inside contents of the cell. Yeah, if this was broad-based, you'd have renal kidney failure. Okay, well, let's look at a different tissue. These are examples of some of the types of histology that you might see on the exam. Okay, straight from the lecture. I'm getting some questions from students. I read the chapter, it took a long time. Good, you're supposed to. There's a lot of information there, I know. However, my whole goal is to expose you to this, and then in lecture to focus it to a narrow range so that you know what you have to study for the exam to be successful. So if you focus on the lectures, that's the material where I will write the test questions from. Okay? But the value of the broad exposure is it's there somewhere. It's not, you've heard of it. You may not remember it very, very well, but the next time you see it, it won't be completely foreign to you. Okay? Now, I've had lots of feedback from students that moved on into PT school, into medical school. Okay? Did I tell you guys a story about an old student in med school who wants to be a pathologist? Oh, I'm so proud, right? He's like 6'2". I'm like, oh, I'm so proud of you. Bend over and give me a hug, right? So you will have heard it and exposed to it, but to be successful in this class, I feel like it's more fair to help you focus your attention, and that's why I want you to focus on the slides. Okay? So this is what tissue. What does this look like up here? It's even labeled with zones 1, 2, and 3 for you. What's that? It's not pancreas, but it's close. Pancreas. It's liver. Okay? Liver tissue. So liver tissue, it's organized in lobes, right? And these are different zones. And you can see right here, you've got a nice big vein in the liver. Okay? So these are normal hepatocytes here. Now, the fatty change that takes place in a cell during a necrotic process is most well observed within liver tissue. And we call it fatty liver disease. And we'll get there when we talk about the endocrine diseases, and we get into kidney and liver disease, okay? And everybody kind of knows what stimulates fatty liver. What's one thing that can stimulate fatty liver that's very common? Alcohol, excessive use of alcohol. Okay? But this is reversible. The liver is a tremendously aggressive organ with respect to regenerative potential. And so if you look at the lower picture, these are all vacuoles that are now organizing within the liver. Well, if you remove the alcoholic insult, these vacuoles will reabsorb and you will regenerate back to normal-looking hepatic tissue. The point of no return is when this is replaced, and you're starting to see a little bit right here, this is replaced with scar tissue, fibrotic scar tissue. And when the liver becomes scarred, and it's a fibrotic wound, it is no longer reversible. And that's called cirrhosis, and we'll talk about that later in the semester. Okay? Now, in contrast to necrosis, I want to talk about apoptosis. And apoptosis is quite fascinating because it's a mechanism that we use, and we even use it during development. So everybody hold up your hands. Look between your fingers. What do you see? What's that? Your neighbor? Right? See another student? Not skin. Okay? Hair? So in utero during development, there was actually tissue there. Right? Probably many of you have seen these photographs in basic bioclasses. Right? Well, there was a signal during development that said this tissue needs to die. Here, 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 here. Right? And everybody has a friend that's got a funky toe, right? So the webbed feet, the webbed situation is a abnormality, but it's a breakdown in the apoptotic mechanism, where in that particular location, it didn't completely tell the signal of the cell, the signal didn't tell the cell to completely die off the way that it needed to, to have interdigitating appendages. Okay? So that's an example of apoptosis that all of us go through during development that is a normal, healthy process. Okay? It also happens in us today, even now. We're out in northern Arizona, we're at 7,000 feet. The sun is very strong here. So, all day long you are exposed to radiation. And your body deals with that radiation and handles it and manages it pretty well. And in some cases, it'll signal a cell to go through apoptosis and die, and then it recycles its parts. The reason is because it has determined that there may be damage to the DNA, and I don't want that cell to propagate that damage and then become a cancerous mass. So all day long, you and I are working hard to manage cancer-causing insults in our environment. And we do it quite well. We do it much better when we're younger than we do when we're older. Okay? So cancer is a more prevalent disease in an older population, but it does not mean that it does not exist in pediatric patients. And we all have sad stories that we know about. Okay? But apoptosis is very different than necrosis in the sense that it is a normal physiologic process, whereas necrosis is a pathological situation, or it's a result of a pathological insult. Apoptosis is also referred to as programmed cell death. It's organized. It creates these membrane blebs, and they break off. So it's almost like, you know, these intergalactic space movies, right, where the mothership's going to blow up, you know, and the countdown's going on, and they get in their little escape pod capsule, right? They hit the button, and they shoot out to freedom, right? Who knows where the heck they're going, but they're safe. So that's kind of apoptosis. It sends out these little apoptotic bodies as like these escape pods, and those are phagocytosed and used by neighboring tissue and neighboring cells. Okay? And as an apoptotic body, you can actually kind of appreciate there's entire organelles in there. It's like going to a garage sale where, you know, there's actually functional, like, you know, a refrigerator, and there's like an entire bike, and there's like a wakeboard, okay? It's not like you just bought a tire or, you know, you bought the top rack of the dishwasher. So apoptosis gives you fully functional organelles at times, and it sends them out, and they can be recycled, okay? In the very back. They can be recycled and reused. That's correct. That's exactly. It's very green. It's a very green process. Okay, it's very popular in Flagstaff. Apoptosis. That would be the. I think someone should have that as a band name. Just throwing it out there. Apoptosis. Yeah. So apoptosis is very organized. Okay. The key with apoptosis is that the membrane itself stays intact. So you can see here the membrane has never been compromised. All of these little apoptotic bodies get shot out, and they never breach the integrity of the membrane. So it's like the cell is slowly winding down, and you're kind of moving out in a very organized fashion. Over here on necrosis, it's kind of like, you know, your roommate that moved out last night in their car, and everything just went into the car. It was not even a box. Okay, it was just like they backed it up, shoved it all in, okay, like a tarp went on the ground, all the stuff went in the tarp, and then they carried it out and put it in their hatchback, okay? This is that situation. This one is, you know, the roommate that started moving out like 2 months ago, and every box is labeled like kitchen, bathroom 1, you know, bedroom, closet, right? All the boxes are labeled, you know, those kinds of friends. So those are apoptotic friends. So what I want you to do right now is I want you to spend some time comparing and contrasting. Look at this list of apoptosis on the left versus necrosis. Take a look at some key differences. Okay, now that you have that, you can team up. Don't shout out the answer, okay? I want you to take a look at these two pictures. This is a scanning electron micrograph. They're both taken at the same magnification. It's a 5,000x magnification. Electron microscopy. And I want you to tell me two cells, cell A and cell B, which picture of a cell, A or B, is representing necrosis and why? Not just what is it that leads you to that answer. So come up with the answer and then turn to your neighbor and share your answers and see if you guys got the same answer. You guys all agree? Everybody have an agreement, or who's disagreeing? What group disagree? You can't seem to agree. So everybody's in agreement? So everybody will get this correct on the exam? Okay, sweet. So what's the answer? Which one is a picture of necrosis? B. Why? Give me some, raise your hand. Let me hear some answers as to why up front. Loss of membrane structure. I would agree.
I was going to say the integrity of the cell has been diminished. There's no cell tissue in the middle and stuff.
So the integrity of the cell membrane has been lost. You can see like a giant hole here and here. Whereas here you don't see holes. Okay? I agree. Any other ideas? Yeah? No, the holes here are just because the membrane itself, the integrity of the membrane itself is gone. And one of the reasons is because you activate what we call phospholipases. We'll talk about that after the break. But the phospholipases that get activated, they start breaking down the membrane because the membrane is made up of phospholipid bilayer. Okay. Any other reasons as to why this is necrosis, or maybe a better question would be, what is this then? Apoptosis, and why would you call it that?
It looks like it's doing the blooding.
It looks like it's blubbing right now, doesn't it? Yeah, it's like that's a dance move or something. This is, you know, it's not the nay-nay, this is the bleb. So it's blubbing right now, right? I know I said this. I have 2 junior high grades, so I know what the nay-nay is. But don't ask me to do it, because they laugh at me. But if I'm in the mall with them, I will totally be nay-nay, because it makes them really embarrassed. So this is a total bleb right here, right? And it looks like it's coming out at you.
So we actually have like organelles inside.
Yeah, I mean, it's hard to tell what's in there, but it is large enough that you can appreciate it's probably packaged with something useful. Okay, it might be a dishwasher in there, or, you know, refrigerator, a little mini fridge, a little dorm fridge. Okay, so pretty clear? Apoptosis versus necrosis. So as we kind of wrap up this little segment, and let's take a break after this slide. This is an example back to the kidney. And when we get into the renal section of the class, we're going to start looking at acute tubular necrosis, which is really what this is. This is acute tubular necrosis that's due to a kidney infarct. And then the tissue of the kidney becomes what we call coagulative and necrotic. And we'll cover that after the break. Because you probably read a little bit about the different categories of necrosis, right? And the different types, subcategories of necrosis. So that's what we're coming to next. This is non-reversible or irreversible. You get nuclear degeneration, like you pointed out in that previous slide. So you can see in this particular sample, there are no purple dots really. Well, here's a couple right here. But you see like these round tubules, there's no nuclei in them. They're completely anuclear. All of these tubules Here's 2 little nuclei left over, right? Little lone survivors. But if it's anuclear, it can't regenerate. The nucleus is what gives the cell its ability to regenerate. That's where the DNA is found. Okay? So let's take a break, and when we come back, we'll pick it up here with the types of necrosis.